Welcome to Healthcare Musings, a podcast dedicated to the discussion of critical care, the medical field, and healthcare in general. Here is your host, Dr. Hassaballa. Okay, happy to have you with me. So, a lot of times, as you may or may not know, I am in addition to being an intensive care specialist, I am also a physician advisor. And physician advisors, for those who don't know, are physicians who are specialized in advising hospitals on the proper status of patients when they get admitted to the hospital, either at the inpatient level of care versus the outpatient level of care or observation. And part of their job is to appeal insurance company denials. And so as a physician advisor, I have actually focused my physician advisory work on writing appeals of insurance company denials. A very common insurance company denial that I see is something called the DRG denial. And we had another podcast episode about what a DRG denial is. And I refer you to that on the website, healthcaremusings.com. And it's under the section called From the Appeals Desk. So basically what a DRG denial is when the insurance company will say, you know what, this particular diagnosis was not present when we did a quote post-payment audit, right? They'll pay the hospital for the hospital stay, then they'll do an audit, and they say, actually, you know what, you owe us $5,000 because you really didn't have such and such diagnosis, and so we overpaid you. And one of a very, like sepsis, another very favorite diagnosis that they love to deny is acute respiratory failure. The reason they deny diagnoses like these is because that when you get rid of sepsis or you get rid of acute respiratory failure, you dramatically decrease the severity of illness. And when the severity of illness goes down, the payment goes down. It's very simple, right? So they go and they say, oh, well, there was no acute respiratory failure. And then they can ask for money back. It's very annoying and disingenuous, but they do it. And they're going to do it more because, and we talked about this in a previous podcast episode, Medicare Advantage plans now have to follow the 2 midnight rule, which means that they're going to be on the hook for paying for a lot more inpatient hospital stays. And so a way to get money back is to then to scrutinize our documentation and then try to argue that various diagnoses were not present. So acute respiratory failure is a very common one. So what I see a lot, and it's based on articles such as there's this article about acute respiratory failure in a magazine called The Hospitalist, where they say that acute respiratory failure has to have two of the following out of 3. Number 1, signs and symptoms of respiratory distress. Number 2, low oxygen levels, such as a partial pressure of oxygen less than 60, or elevated carbon dioxide levels, a partial pressure of carbon dioxide more than 50 with a pH of less than 7.35. And my problem with that, where I disagree, and my contention, is the issue of respiratory distress. Because in its essence, respiratory failure is a failure of pulmonary gas exchange, period, full stop. That's all it is. It has nothing to do with respiratory distress. Now, the reason I say that as a pulmonologist is because respiratory distress is a consequence of the failure of the pulmonary gas exchange. The reason they're in respiratory distress is because they cannot oxygenate or they cannot ventilate. But let me tell you, it is not, you don't have to have it because, and COVID-19 taught us that. During COVID, I can't tell you how many patients came into the hospital with absolutely no distress, but their oxygen saturations on a documented arterial blood gas in the arterial blood was 50%. That is clearly acute respiratory failure with hypoxia, and they have no respiratory distress. Same thing with hypercapnic respiratory failure. There are patients I've seen all the time who are comatose from hypercapnia, like an opioid overdose. They have absolutely no respiratory distress, but they're comatose because their carbon dioxide is over 100. They clearly have acute hypercapnic respiratory failure. Again, it has nothing to do with respiratory distress. So that was really unfortunate that article said that. And it's really unfortunate that article said that, and then the insurance companies use that as the rationale. No. Acute respiratory failure is a failure of pulmonary gas exchange. If the lungs cannot maintain adequate oxygenation, which as a pulmonologist is either a PO2, a partial pressure of oxygen, less than 60, or an oxygen saturation less than 90. And I have another podcast episode during my lectures about respiratory failure and why PO2 really doesn't matter. As for hypoxia and for hypercapnia, it is a PCO2 more than 50, meaning partial pressure of carbon dioxide more than 50, with a pH less than 7.35. Because there are people who are chronically hypercapnic and they don't have respiratory acidosis, so that's not acute hypercapnic respiratory failure. Okay, that's it. That is what it is. Has nothing to do with respiratory distress. The other essential component, and insurance companies love to see this on this, is about airway patency. Okay, in order for you to adequately exchange gas, you have to have an open airway. You have to have a patent airway. So you have to have normal upper airway reflexes in order to maintain a patent airway so that you can have adequate pulmonary gas exchange. And there should be no obstructions. For example, if you choke on a piece of steak, you have an obstructed airway, and that quickly leads to acute respiratory failure. Okay? When you are comatose from a drug overdose, for example, you cannot maintain normal upper airway reflexes, and then the airway is not patent, and then you lead to a failure of pulmonary gas exchange. So this is why we clinicians say, well, they were intubated, they were placed on a ventilator for airway, quote unquote, airway protection. Well, what they're saying is the patient cannot maintain a patent airway, therefore they have respiratory failure, and therefore I'm putting them on a ventilator to treat the acute respiratory failure. But what we do, because we don't want to, I don't know why we don't want to take the time to document, we write airway protection. And the insurance company seizes on that, and they say there is no such diagnosis as airway protection. And they are technically correct. So we give them the knife to stab us in the back. What we have to do is to be more precise. And so I don't, and this came from a case I had where a young kid, arrested at home, had a cardiac arrest at home, and they brought him in and they put him on a ventilator right away because he was completely comatose, and they denied the respiratory failure because there's no evidence of low oxygen, no evidence of high carbon dioxide, and airway protection is not a diagnosis. And I appealed that, and I said, no clinician in their right mind is going to let a kid sit there who's not breathing because they're in cardiac arrest until they document low oxygen or high carbon dioxide. And they upheld the denial, saying there's no such thing as airway protection as a diagnosis. So that was so telling. And so now what I document in the record, and this is true, I will say the patient is suffering or is critically ill with acute respiratory failure secondary to the inability to maintain a patent airway due to toxic metabolic encephalopathy from an acute opioid overdose. I will write that in the record. Is it a handful, a mouthful? Yeah. Do I have to type more? Uh-huh. But that is the way I will not give an insurance company the knife to stab me in the back. You have to be more precise. Because again, they have to they have to follow the 2 midnight rule, Medicare Advantage we're talking about. These DRG denials are going to be much more prevalent and common. So we have to be much more sophisticated in our documentation. But at the end of the day, Acute respiratory failure is about two things and two things only. One, airway patency, and two, a failure of gas exchange. When either of those are not present, or if either or an adequate, I meant adequate gas exchange. If either are not present, if there's not a patent airway or there's a failure of gas exchange, that is acute respiratory failure. Okay, period. Has nothing to do with respiratory distress. Thanks so much for your time and attention. And until next time, this is Dr. Hashem Hassaballa signing off on Healthcare Musings.